Assalamu alaikum and good evening to you all. Welcome to the sixth episode and the final episode of Masterclass for Medicine Final Part Examinee organized by SCP Bangladesh Chapter and supported by Bangladesh Society of Medicine. As you already know, it is a program which is designed for the Medicine Final Part Examinee as well as Midterm Preliminary Part 2 examinees. Today is the last episode of our program and we have saved the best for the last. Today, we will be learning about the management of hypertension. As we already know, every clinician must have the knowledge about this topic. To teach us about this topic, we have one of the best clinicians of our country, Professor Muhammad Mujibur Rahman sir. He is the Professor of Medicine, BSSMU, and Vice President of Bangladesh Society of Medicine. To chair the session, we have someone who is considered a true leader and a prodigy in the field of medicine. He is none other than Professor Khan Abul Kalam Azad sir. He is the Governor-elect of SCP Bangladesh Chapter and former President of Bangladesh Society of Medicine. In the expert panel with us, we have two most renowned and prestigious professors of our country. Firstly, we have Professor Enamul Karim sir. He is the head and professor of medicine, Universal Medical College. Then we have Professor Major retired MD Julshash Uddin sir. He is the head and professor of medicine, Marks Medical College. As a moderator, we have the talented Dr. Muhammad Mahfuzul Haq sir. He is the assistant professor of medicine, Dhaka Medical College. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand off the session to Dr. Muhammad Mahfuzul Haq sir. Dr. Muhammad Mahfuzul Haq sir.
Thank you, Dr. Prince Kawser. Assalamu alaikum and good evening to all. This is a program which has been routinely organized by the American College of Physicians and supported by Bangladesh. Very delighted to be part of this program. And at the first, I want to give thanks our very respected Professor Khan Abul Kalam Azad sir, Governor SCP, and who will chair this session today. I would like to also mention that today's topic, that is management of hypertension, is going to presented by Professor Mujibur Rahman sir. And there is nothing to say about the Professor Mujibur Rahman sir, particularly in this topic of hypertension. Once our Professor Mujibur Rahman sir told that if someone asked him to become which kind of specialist he want to be in his postgraduate training, he told that I want to be a specialist of hypertension. So it's assuming that how much interest Professor Mujibur Rahman sir has in the hypertension. And he has several papers on the hypertension. And we are also delighted that we have two panel of experts, Professor Mohammad Julshash Uddin sir and Professor Enamul Karim sir, who both of them are very much talented and they are very much learned. And we think, I think this program will be very interesting. And the program, which is intended for the student, will learn many things. And as we know, the hypertension is the one of the clinical condition. It is estimated that it is about more than 1.5 billion of people is suffering from hypertension worldwide, and about 1 billion of them in the low and middle income country. And not only that, not only the prevalence of hypertension and the clinical importance, it is also important in the exam settings. It is asked in the particularly in the interactive oral session, which has been recently introduced in the exam setting of the Bangladesh Physician BCPS. And there are in various types of settings in the exam, it is usually asked or it is said. So the management of hypertension, though it is very common, and but it is sometimes maybe a topic which can lead to a student a bad outcome. So everybody of us should know the hypertension. So before starting the going to the Professor Mujibur Rahman sir, I want to go to the Professor Khan Abul Kalam Azad sir to start the program.
Thank you very much, Dr. Mahfuz, for your excellent words regarding such a scientific presentation. American College of Physicians, the way it is progressing and also taking the charge to help the students and also incorporating our great scholar teachers in this context is a wonderful happening. And I like to say that Professor H.M. Nazmul, our honorable governor, he is always a philosopher, a great thinker, and definitely the important aspects of clinical medicine are always very much important for a trainee doctor for the future and also for the examination. And truly speaking, before going to the meeting, I will definitely put some remarks later. But Professor Mujibur Rahman is such a scholar. I don't need to introduce him, but he is a very, very great collaborator of medicine. He is such a wonderful person whose brain always works with your students' welfare. And our two great teachers, two very great souls of the soil, Professor Enamul Karim and Professor Julshash, they are very kind-hearted people and also great teachers, long time experience. They are here. So also our new scholar going to be Dr. Mahfuz, and also young, our anchor, Dr. Prince, and also for whom the meeting is there, all the participants, because all the participants, when they participate, a meeting becomes successful. So Professor Mujib will be successful, our experts will be successful, I will be successful, SCP will be successful if our participants understand the topic, the lecture, and also we invite many questions from the student. Thank you very much. Without delay, I like to request Professor Mohammad Mujibur Rahman to begin his excellent speech, what I would say. Thank you very much, Professor Mujib. Please go on.
Thank you, Mr. Chairman, the SCP Bangladesh chapter's governor-elect, Professor Khan Abul Kalam Azad, and also two other eminent professors, Professor Enamul Karim and Professor Julshash Uddin. All of these three is my guru, is my elder brother, are my teachers. I have learned so many things from them from the very studenthood of my life in the medical colleges. But in front of them, I always remain very submissive. I don't know whether I will be able to present the topic like hypertension in front of them, but I will try my best. Thank you, Dr. Mahfuz, the moderator of this session. Thank you very much. So management of hypertension, in our student life, we owe this management of hypertension to our great teacher, Professor S.G.M. Chaudhary. Everybody here except Mahfuz, me, Professor Abul Kalam Azad, Professor Enamul Karim, and Professor Julshash Uddin, and also the governor of this, the present governor, SCP Bangladesh chapter, Professor H.A.M. Nazmul Hassan, all are the students of Professor H.G.M. Chaudhary. We are very much thankful to him. May Allah place his soul in the Jannah. Anything, if we can learn, if we have learned anything in medicine, that goes to him, and we all are owed to him for the clinical medicine and also teaching of hypertension. Hypertension itself is a specialty that has been told by Professor S.G.M. Chaudhary in our undergraduate lectures. And I have seen him coming to the lectures with a very small hand notes, and that was taken from the then JNC, Joint National Committee. He started, we got from JNC 3, 4, 5, etc. from him. So now I am going to my topic now. The management of hypertension is we have to understand about the burden of hypertension first. Hypertension is a great burden throughout the world and also in our country. If we see the world burden, that this hypertension affects more than 30% of the adult population worldwide, more than 30%. If you consider 18 years and above, then it comes to more than 1 billion people around the world has been suffering from hypertension. It is the main risk factor for cardiovascular diseases. What are those? The cardiovascular diseases, the coronary heart disease, stroke. Stroke is a cardiovascular disease. Nowadays, the nomenclature has been changed. Cardiovascular is not only the blood vessel disease and also is not only the cardiac diseases. CKD is also one of the important cardiovascular disease. Heart failure is a cardiovascular disease. Arrhythmia is among them, and also dementia. This chronic dementia, chronic hypertension will lead to the development of loss of brain function and ultimately will be leading to dementia. So these are the important cardiovascular diseases that will be coming from the effect of hypertension. So hypertension is very important. If we see in our country, again, this is global prevalence. The global burden of diseases in 2012 is around 8 years old. They have been told that the 29% will be by 2025, but you have seen that in the previous slide that it has been already 30% worldwide. So next slide, please. In Bangladesh, the burden, again, next slide, yes. Next slide. In Bangladesh, we have 2 studies done in Bangladesh. One in 2010, another is 2018. In 2010, the prevalence was around 20%. On the other hand, in 2018, it is around 21%. So in these 8 years of time, there is not much increase in the total prevalence of hypertension, but there is some changes among the male-female distribution of the hypertension. You can see here. So these are the most important publications from Bangladesh perspective. Next one, please. Due to some technical difficulties, I am not able to share my slides, so I am asking Dr. Prince to share in favor of me, and that is why I have to say every time, next time, please. Okay, thank you, Prince. This is the slide from our study. It has been shown that as the age is going up, the prevalence of hypertension is also going up. You see, in the age group 65 and above, the rate of prevalence is 41%. On the other hand, 25 and 34, this 10 years group is only 6.8%. So as the age increasing, the prevalence is gradually increasing. So this next one, please. In this slide, I want to say about the definition of hypertension. With this definition, there are some much confusion and there is again very much disagreement between the scientists about the definition. But still, we will be taking these as the definition of hypertension, as blood pressure is more than or equal to 140/90 should be considered as hypertension. But you see, a patient has come to you and you have measured the blood pressure is 150/92. But this single measurement, by this single measurement, you cannot take that individual as hypertensive. So there must have been at least 3 measurements, at least 1 week or more apart. If that individual fulfills this definition, this cutoff value, then that individual will be taken as, will be labeled as hypertensive individual. So single blood pressure recording cannot label an individual as hypertensive. This is very important. Next one. 2 terms we are used to habituated during the definition of hypertension. One is white coat hypertension, another is masked hypertension. What is white coat hypertension? I think you all know what is white coat hypertension. The white coat of the doctor or the appearance of the doctor in front of the patient will increase the sympathetic overactivity and lead to the transient rise of blood pressure. Every time the patient comes in front of a doctor or an individual with white coat, that individual will be having a bit of higher blood pressure level. This is what is called white coat hypertension. And how to eliminate this white coat effect, I will be describing a bit later. Masked hypertension. What is masked? This might be a new terminology to some of you. Masked. That is, the hypertension, the blood pressure becomes low whenever the individual comes in front of a doctor. This is a very rare phenomena. White coat is a very common phenomena. On the other hand, the masked hypertension is a very rare phenomenon. So, but it can happen still. You have to remember, and that is why you always need to do measuring blood pressure at the home. Prince, next one, please. Blood pressure classification. The blood pressure classification, again, this is a very inconvenience whenever I discuss this classification of blood pressure, because there are much confusion among the scientists, among the hypertension specialists throughout the world. But JNC 7 that has been published in JAMA in 2003, that was a very elaborative classification criteria and also guideline for management of hypertension. This classification, you see, normal is less than 120/80. Pre-hypertension is between 120 to 139 systolic and 80 to 89 diastolic. So this is pre-hypertension, and subsequently this definition of pre-hypertension has been obsolete by the American authority, and the stage 1 hypertension, stage 2 hypertension. You see, in JNC 6, JNC 5, there were stage 3 hypertension also. But in JNC 7, they have been described that the leveling of stage 3 or 4 or more is is not needed, because the implications of stage 1 from starting from 160 systolic or diastolic starting from 100 is same if you consider the implication of blood pressure above 180 degree, 180 millimeter, not degree, 180 millimeter of mercury. So they have been merged these two stages, because the management and the implications and the prognosis all are same. So only stage 2 is enough to designate more than 160 or more than 100 millimeter of mercury, and that is why it is being used in further. One thing I want to mention is that JNC. You know, JNC is Joint National Committee. Joint National Committee is a body that has been proposed by National Heart, Lung and Blood Institute of NIH. NIH is an authority institute of United States, and it has several institutes and several authorities. National Heart, Lung, Blood Authority is one of them. This National Heart, Blood, Lung Institute has been proposed, JNC 8, after being published this one in 2003. But by the end of 2013, they are not able to propose the guideline for management of hypertension. This long more than 10 years of time. But there are some reasons, there are some disagreement between the authorities, and that is why it was very difficult to put forward with the uniform recommendation. And subsequently, that National Heart, Lung and Blood Institute, they withdrawn the mandate from the JNC 8 to put forward the guideline. And subsequently, the total authoritative commitment was given to American College of Cardiology and American Hypertension Association. These two organizations has been given the authority of put forwarding the guidelines for hypertension. But at that time, very rapidly, those committees, JNC 8, they published a hurried guideline in JAMA 2014 or 13 probably, but I don't use that JNC 8 because their formation was subsequently taken by the authority. So that JNC proposed that JNC 8 guideline, and that was a very troublesome and very difficult guideline. But subsequently, the next one, please, Prince. This guideline was proposed by, this classification was proposed by ACC and AHA in American Heart Association in 2017. They have been put forward normal as before, less than 120 by 80. Elevated is 120 to 129, and less than 80 is elevated. And hypertension more than 130 is hypertension. So the definition of hypertension has been changed here. You see, they are telling that though this is late of the guideline, so if you can remember this one, it's fine. So here is no term which is called pre-hypertension, and stage 2 is more than 140. So you see, this proposition of guideline or classification of blood pressure was made due to publication of an important article which is known as Sprint. I know everybody of internal medicine training must know this Sprint. Sprint was a trial. I will be just saying something on Sprint. Is tight control of blood pressure less than 120 by 180 and another group was less than 140 by 90, the conventional definition. So they shown that there was a tremendous amount of benefit whenever there is blood pressure target is less than 120 by 80. So that is why the total definition has been changed depending on that sprint article, sprint trial. So if you can remember this one, fine, because for the student, if you use any of this classification, আমি আরো দুইটা classification দেখাবো that might confuse you more, but I would suggest you that you remember one. Anything you say from these definitions, everything will be accepted by your teacher, by us. Next one, please. This is the classification. You see, every time anything on the both parts of the Atlantic Ocean, there is a great division. The eastern part of the Atlantic Ocean, they think in such a way that the western part of the Atlantic, they thought in a different way. That is why there is some sorts of disagreement between these classification criteria. So, my dear trainees and students, if you use anyone, this has been written in your Davidsons, is well, no problem. You can tell this one also. So next one, please. This is the nice guideline, British guideline. This is also in conformity with the European diagnostic, European classification. Next one, please. How to measure blood pressure? Blood pressure measurement, there are several types of measurement of blood pressure. One is called office measurement, home measurement, and ambulatory BP measurements. Next one, please. You see this. This is, you know, the measurement of blood pressure is very important. Is a paramount importance. That is why this year WHO slogan is measure your blood pressure accurately, control it, and live longer. Because the management of blood pressure is very much dependent on the measurement of blood pressure. There are so many things. Only measurement of blood pressure might need one lecture class. If you ask Professor Kalam Azad, if you ask Professor Enamul Karim or Professor Julshash, they will take one class only for the measurement of blood pressure. But I am not going into the details. You must have to be very cautious. There are different types of manometer. This has been shown is the electronic device. Not all electronic devices are the very good device. The Omron, we usually accept Omron is a very good device. আমি কোম্পানির পক্ষে বলে ফেললাম, কেউ কিছু মনে করেন না। And how to choose the size of the cuff is very important. Is a very big fatty individual, very slim cuff. It's not. It should at least encircle 2/3 of the arm circumference, and it should be very well placed over the arm, and there should have around 1 inch place between the cuff and the cubital fossa, the midline of the cubital fossa. So এইটুকু জায়গা রাখতে হবে to place the stethoscope. Please don't push the stethoscope behind the cuff. It's a very placement of the bale of the diaphragm of the stethoscope behind the cuff. Again, if you deflate the, আমি খুব সংক্ষেপে বলে যাচ্ছি, during deflection, don't deflate the cuff like শেষ হয়ে গেল, ডাক্তার সাহেবের ব্লাড প্রেশার মাপলে এরকমই হয়, করে নামাই দিল, শেষ। No, 2 millimeter per second. It would be 2 millimeter per second, and that is why inter-observer variation is a great. আমি ব্লাড প্রেশার মেজারমেন্ট আমার ইন্টার্নিদের দেখিয়েছি, আমার ব্লাড প্রেশার মেজারমেন্ট আমি আমার ট্রেনিদের দেখিয়েছি, এবং inter-observer variation is a great variation. During the if we see the blood pressure reading, It's 175 by 95. It means that you did not look blood pressure very carefully, because in our aneroid manometer, there is nothing say 95, there is nothing 75. It would be in the range of 2 digits. So it would be 96 or 94. তার মানে আপনি average করেছেন. So this avoidance of this the averaging of the figure of blood pressure, but sometimes it can happen with these sorts of manometer like electronic device. Yes, it can happen. Next one is home blood pressure measurement. Home blood pressure measurement, once upon a time, our professors did not allow the patient to measure blood pressure at home. But nowadays, to eliminate the effect of masked hypertension, to eliminate the effect of white coat hypertension, we should also measure blood pressure at home. So we have to choose which patient should be selected in these particular cases. And another measurement technique is ambulatory blood pressure measurement. আমরা সাধারণত এটা করি না, অনেক দামি মেশিন, এটা আমাদের প্রাইভেট প্র্যাকটিস বা হসপিটাল প্র্যাকটিসে আমরা ইউজুয়ালি ইউজ করি না, অনলি রিসার্চ পারপাজে হয়তো কোনো জায়গায় এটা ইউজড হতে পারে। তো দেয়ার ইজ সাম করেসপন্ডিং ভ্যালুজ, আপনারা যে অফিস বা ক্লিনিক ব্লাড প্রেশার, that clinic blood pressure corresponds to home blood pressure measurements like this. If we go below, if it is 120 by 80, the home blood pressure is the same. The daytime ambulatory blood pressure measurement is the same. The nighttime blood pressure measurement will be a bit lower, onek lower hobe in the night time. But average 24 hours is 5 less than the clinic blood pressure measurement. You see? If it is 130 by 80, if the clinic blood pressure going up, the difference is also going up. Eta mone rakhar kono dorkar nai. Next one, please. What আমরা blood pressure ke usually we classify blood pressure like this: the primary or essential hypertension. The term essential hypertension is now obsolete, because essential means it can happen with us, it can exist with us. No, it can be a comparable disease with malignancy if remains untreated. So hypertension, it's a primary hypertension or it can be secondary hypertension. So we will not use the term essential hypertension. Understand? So secondary hypertension, whenever the hypertension comes, it means the primary hypertension. In our settings, it usually less than 90 to 95% of the total population of less than 5 to 10% of the total population of hypertensive individuals are secondary hypertension. So in my whole discussion, I will not say anything about secondary hypertension. But now, what are the secondary causes of hypertension? And how will you find a clue to the presence of secondary hypertension? I'll just mention 2 things here. The important cause is kidney. There are several kidney diseases that is linked to secondary hypertension. You all know, I'm not going into the details. Pregnancy, the endocrine diseases, some like thyrotoxicosis, like the pheochromocytoma, like Cushing's, and these are some of the endocrine causes. And other causes, the congenital is coarctation of the aorta. So these are the secondary causes. I'm not going, when you will suspect a patient having been with secondary hypertension, there are some important clues, important problems. A young individual has come to you in his 30s with sudden rise of high blood pressure, with excessive sweating and flushing of face, and again after having been sedated the patient, the condition is reversed. And so this sorts of paroxysmal rising of blood pressure leads to the suspicion of pheochromocytoma, or an individual in his 30 having been very high rise of blood pressure in stage 2 যদি আমি আমেরিকান ইয়েতে বলি, or stage 3 in European standard of definition, and not responding to usual treatment and not responding to usual combination of drugs, then think of the presence of secondary hypertension. And this much about secondary hypertension. Next, the risk factors for essential hypertension. Why do we develop hypertension? The risk factor, you see, if we consider the non-communicable diseases, there are some sorts of risk factors in the community, risk factors in the middle, and the target diseases. So hypertension basically is not a disease, is a risk factor for the development of other common cardiovascular diseases, or the NCDs, common and non-communicable diseases. And hypertension is an intermediate risk factor, and hypertension again is coming from age, or that is elderly, obesity, family history, race and ethnicity, high sodium diet, physical inactivity, excessive alcohol consumptions, and reduced numbers of nephrons in the adults. Reduced number of nephrons, this is very tricky term, reduced number of nephrons, because whether this reduced number of nephrons is giving rise to hypertension, or hypertension is leading to this reduced number of hypertension, is a tricky question. Which one is first, the hen first or the egg first? I am not going into those debate. And next one, please. Hypertension. Our patient usually tells us that, Dr. Saheb, আমার তো মাথা ঝিমঝিম করে, আমার যদি ব্লাড প্রেশার 140/90 উপর উঠে যায়, আমার ব্লাড প্রেশার একদম ঝিমঝিম করতে থাকে, ব্লাড প্রেশার আমি বুঝতে পারি যে আমার এরকম মাথায় উঠতেছে। অর্থাৎ as he described that his head and neck is the manometer for blood pressure measurement. So these are the psychological issues you have to keep in mind. Usually blood pressure is asymptomatic, but rarely it can cause some of the symptoms. Those are headache, neckache, dizziness, and vertigo, blurring of vision. So these are some of the important clinical features. Those can happen in very high rise of blood pressure, and sometimes these symptoms may happen without being rise in blood pressure in too much degrees. So you have to judge the patient very carefully. But in most of the situations, blood pressure is asymptomatic. That is why it is being labeled as silent killer. You see, a rickshaw puller or a day laborer working in the village or in the street, but he doesn't have any symptom. Once upon a time, he came to the hospital in the emergency department of any hospital. He was found to be unconscious, and on measurement of blood pressure, it was more than 200 systolic and diastolic blood pressure. And the patient's family members, they all are unaware about the presence of hypertension previously. That is why it is called silent killer. Next one, please. Complications of hypertension. These are very common thing. I think you all know all these things, starting from the brain top to the toes. Every organ can be affected. Every vital organs can be affected by hypertension. Next one, please. Why should we treat hypertension? As I have told that it has got no symptoms. So why should we treat hypertension? The not to reduce only the blood pressure. We have to reduce the mortality, we have to reduce the cardiovascular and other target organ damage by the hypertension. That is why we have to treat the hypertension. Next one, please. Next one. Yes, from observational data, এটা আমি বহুদিন যাবত এই স্লাইডটা দেখাই because I love this slide. You see the blood pressure, rise of blood pressure increases the cardiovascular diseases. The observational data shows that. The observational studies, those were done in 50s, those were done in 60s, only observational data showing that the cardiovascular diseases are increasing. And subsequently, if we treat the hypertension, the cardiovascular diseases is reducing. So this is very important. That is why we have to treat the hypertension. Next one, please. You see here in this slide, the men and women, this is the hypertensive individual, this is normotensive individual. The coronary heart disease is increased substantially among the hypertensives. You see, this was the study published first in 1961. 1961, this is observational data. The Framingham observational study, they started doing it from 40s, 50s and published in 61. On the other hand, it was published in 1970 that the Veterans Administration study, there is a cohort. Among this cohort, the treatment was showing tremendous benefit among the hypertensive individuals. You see, active treatment, there is far less number of endpoints. Next one, please. I don't want to say anything about this slide. This slide shows that only if any degree of reduction of blood pressure can give benefit. So benefit occurs from reduction of blood pressure. এটা আমাদের অবশ্যই মনে রাখতে হবে. Next slide, please. These are the benefit, showing benefit, active treatment better, active treatment worse. So this is a blogogram by forest plot showing active treatment is better. All the studies, few of them I'll be discussing later on. Next one, please. আমার কাছে কন্ট্রোল থাকলে আমি খুব দ্রুত চলে যেতে পারতাম, তো এগুলো আমি খুব বেশি দেখাতে চাই না. নেক্সট ওয়ানে চলে যাও. Yes. Which blood pressure is important? Which blood pressure? Is it the systolic or diastolic blood pressure? এক সময় আমরা যখন ছাত্র ছিলাম, আমাদের স্যাররা যখন সিনিয়র ট্রেনি ছিলেন, তখন only the diastolic blood pressure was given importance. Only diastolic. And systolic blood pressure was not given any importance. Next one, please. If we see some of the studies, this was published in 1992, MR-FIT trial. It shows that if diastolic blood pressure goes up and if the systolic blood pressure goes up, the cumulative incidence of multiple incidence of those death rates of coronary heart disease and death was very high, with increasing both the systolic and diastolic blood pressure. So from the very beginning of the 90s, these studies showed that both systolic and diastolic blood pressure are important. Next one. With few trials, the isolated diastolic blood pressure. If we consider only isolated diastolic blood pressure, in that patient, the systolic blood pressure is normal, less than 140. If diastolic blood pressure is more than 90, that is called isolated diastolic pressure. You see, the isolated diastolic blood pressure has got no impact with isolated and no isolated diastolic blood pressure. The implication is same. Implication is so systolic blood pressure has got some more importance than the diastolic. But once a patient has got systolic blood pressure raised, then the raising of diastolic blood pressure is also important. Next one, please. This is a very recent study. That study was published in 2020. And this is a NESM study published in 2019. You see the percentage of participants with composite outcome. The composite outcome more with systolic blood pressure and also with diastolic blood pressure. But the significance of this is lower than the systolic blood pressure. But this is also important. Next one, please. Hypertension leads to, আমি আগেই বলেছি, hypertension leads to target organ damage. Okay, go on. Next one. Target organ damage, আমি আগেই বলেছি, আমি এগুলো তার বলতে চাচ্ছি না এখন নতুন করে. Next one. So landmark trials, these are the landmark trials in hypertension. আমাদের ট্রেনিদের এই ল্যান্ডমার্ক ট্রায়ালস গুলো সম্বন্ধে একটু ধারণা রাখতে হবে। আমি 2018 এক্সামিনেশনের সময়, FCPS এক্সামের সময় একজন ফরেনার আমার কো এক্সামিনার ছিলেন। তো he was planning to ask about sprint because sprint was published and much debates and the was with these sprint trial publications. So the co-examiner of me was planning to ask, he was asking, if I ask sprint, are your students can tell anything about the sprint? তখন আমি বলেছিলাম, our students definitely know the findings of the sprint, but the term sprint, SPRINT, may not be known to him because this acronym, all these trials are known by some of the acronym. You must know, you must remember this acronym. I don't think all can be remembered by someone, but some of the important acronyms should be because these are the evidences that lead you to choose the antihypertensive drugs, that lead you to choose the scenario in which antihypertensive drug you will be choosing. So next one, please. How to evaluate during treatment. This term evaluation, our trainees must know one thing, that any problem you may ask by your examiner that how will you evaluate this problem? How will you evaluate this patient? So any evaluation comes with history, physical examination and lab tests. একদম এটা মনে রাখতে হবে. This is mandatory for any problem. So why should we evaluate? We should evaluate the patient for the presence of any other cardiovascular risk factors or whether the patient has developed any target organ disease or any complications of hypertension. That is why you have to assess the patient, you have to evaluate the patient. Clear? আমি এখানে আর ডিটেইলস কিছু বলতে চাচ্ছি না, হিস্ট্রিতে অনেক পয়েন্টস আছে, এগুলো বলতে গেলে অনেক সময় লেগে যাবে, বাট দি মেইন থিং ইজ টু অ্যাসেস two things: risk factors, other cardiovascular risk factors, because the hypertension is a cardiovascular risk factors. So a hypertension এর কোনো co-worker আছে কিনা যারা একত্রে হার্টটাকে ডিরেঞ্জ করে দিতে পারে. So for this reason you have to go through history, physical exam and labs. I am not going into the details. Next. CVD risk. The multiple risk factors, you see, if one individual has got one risk factor, the risk of developing cardiovascular morbidity, mortality will be lesser than if one patient has got 3 or more cardiovascular risk factor. So you have to assess multiple risk factors. Next one, please. Next one, আমি এগুলো আর বলে ভারাক্রান্ত করতে চাই না. Next one, please. Yes. These are the risk. Higher BP, the higher, greater is the chance of heart attack, heart failure, stroke, and the kidney diseases. Next one, please. The presence of other risk factors. Next one. You see, this chart is very important. It was published in 1991 in Circulation. You see the cholesterol, the total cholesterol, the high density lipoprotein, lower, kototuku lower, that is important, the smoking, diabetes, and LVH. If one patient has got the blood pressure, hypertension is hypertension, and also this, all the risk factors with it, then the incidence of this 10-year risk of coronary heart disease will be so many times higher than if it is in this level. Orthat no, all are no. Then you can imagine how much important the presence of other risk factors. So you have to assess for this reason also. This is proved by evidences. Next one, please. Other risk factors are very important. Yes, next one. Goals of therapy. Again, there is much confusion around the goal of therapy. The main public health goal is to reduce the cardiovascular and renal mortality and morbidity. This is in short. But when you can achieve this public health goal, then you have to reach a value of blood pressure. What is that? Next, please. The confusion with these. The recommendation done in 2017, the goal is 2017 is a very tighter goal. But before that, the goal was 140/90, less than 140/90. If the patient has got diabetes or renal disease, it is a bit tighter, less than 130/80. But the guideline and the presented in 2017, that is also very tighter, and they did not stratify this hypertension with diabetes and renal disease. They have been put forward less than 120/80 is the target. Those who can tolerate, কথাটা কিন্তু খুব সুন্দর, যারা টলারেট করতে পারে তাদের জন্য less than 120/80 করতে হবে। টলারেট মানে হচ্ছে if you try to tight the control, tight the lower the level very tightly, then some of the patients, those who are elderly, might have some symptoms like dizzy, fall. So in those situations, you have to closely observe the patient, and in those cases only it would be less than 140/90. But in JNC 8, the so-called JNC 8, they have the goal was a very broader goal, and that was being criticized widely. এবং তাদের এমন ক্রিটিসাইজ করছে ইন্টারন্যাশনালি, সে আর বলার মতো না। তো যাই হোক, ওটার আমি যাচ্ছি না ওইদিকে। নেক্সট ওয়ান প্লিজ। সো গোল ইজ less than 120/80. Next one, please. এটা কিছু বলতে চাই না আমি। Next one, please. Strategies of treatment. What are the strategies? There are two ways strategy to treat hypertension. One is lifestyle changes, that is being called non-pharmacological measurement, non-pharmacological treatment, and another one is pharmacological treatment. Next one, please. The lifestyle modification, the term lifestyle modification is one generic term for non-pharmacological treatment. The weight reduction, the DASH diet adoption, the dietary sodium reduction, physical activity. I'm not going into the details. all modalities will have the impact of reducing blood pressure to some degrees. It has been proved by evidences. Next one, please. No, এটা dash da আমি আর এদিকে যাচ্ছি না. Yes, these are the development. You see, after 2001, there, I want to say in 1990s এর পরে আসলে effective কোন antihypertensive treatment আসলে আসেনি. But after that, there are some strategies has been developed. The strategies, the combination, the control, those has been put forward after that. But the main classes of drugs has been developed within 1990s. Next one, please. আমি এখন এখান থেকে দুই একটা স্টাডির কথা একটু যা সংক্ষেপে বলবো। এগুলো বললে অবশ্য খুব ক্লামজি হয়ে যাবে আমার মনে হয়, বেশি হয়ে যাচ্ছে। The SHEP study, it was published in 1991. এটা ক্লোরথ্যালিডন এবং অ্যাটেনলল দিয়ে দেখা যাচ্ছিল যে ব্লাড প্রেশার রিডিউস করে এবং রিডিউস স্ট্রোক বাই 36%. And that is why at that time beta blocker and chlorthalidone was the choice of drug. At that time beta blocker, subsequently beta blocker went out from the scenario by some of the studies. Next one, please. This is another, the cyst euro or the systolic hypertension in the Europe. This also one of the calcium channel blocker with hydrochlorothiazide combination that was very much effective in reducing the cardiovascular morbidity and mortality. P-value were highly significant. It was published in Lancet 1997. Next one, please. So I just want to show this, that all the drugs are effective. If you can reduce the level of blood pressure, then you will get benefit. Some benefit with some drug, some more benefit with some other drugs. The ASCOT, the Anglo-Scandinavian cardiac outcomes trial, in these, the calcium channel blocker and ACEI combination was tremendously beneficial over beta blocker and diuretics. Is extremely beneficial. You see, the p-value were highly significant. Next one, please. The HYVET trial, the very elderly individuals, the treatment of hypertension is very important. Treatment plus perindopril with matching placebo. The importance of treatment is highly, the heart failure reduced by, but the other benefits only, all-cause mortality reduced by 21%, and death from stroke reduced by 39%. These are significant. But stroke reduced by 30%, the p-value somehow rather it was not significant. Next one, please. Yes, this is progress study, perindopril study. Again, perindopril showing tremendous benefit in secondary prevention of stroke. Secondary prevention, already stroke jader ache, recurrent stroke prevention, this progress study showed perindopril, that is the ACEI, is tremendously beneficial. Next, on target trial. This is a huge trial. This on target trial compares the telmisartan with ramipril and also combination of telmisartan plus ramipril. So this study gave us the idea that the combination of telmisartan and ramipril, that is in other words ARB plus ACEI, is harmful, is detrimental to kidney disease and is not beneficial overall. That is the Kaplan-Meier showing there is no separation of the curve. So combination is not needed, or you can use ARB or the ACEI with equal benefit. Which one is more beneficial? So this bigger trial showed no one is more beneficial than the other one. Next one, please. This is the again on target. Next one. The prophecy trial. এখানে tell me certain with placebo. Tell me certain is highly effective in preventing stroke. Second stroke. That is the secondary prevention of stroke. Another like another study that I already told. Next one, please. This study was published in again the same study, the major events, and another important, the new onset of diabetes. The new onset of diabetes with treatment with other drugs and placebo, and treatment with other drugs plus telmisartan. The telmisartan prevents new onset of diabetes mellitus. You see, it may be a class effect. Next one, please. Roadmap trial. I am not going into the details. The only microalbuminuria or mesartan. Next one, please. The SPRINT trial. This is the last trial I want to mention in front of you. SPRINT. You see the cumulative hazard. This is what is called Kaplan-Meier chart, showing the separation of the chart widely after some years of time, and that separation is tremendously beneficial. The intensive treatment group and the standard treatment group. Intensive treatment group is less than 120 by 80, and the standard treatment group is less than 140 by 90. You see the cumulative hazard. Again, the cumulative hazard is tremendously beneficial. This is primary outcome, and this is death from any cause. The primary outcome was composite endpoint of কতগুলো ছিল, তার মধ্যে stroke ছিল, MI ছিল, primary outcome details নিয়ে আসিনি এখানে, and death from all cause is again, death is also much reduced with this intensive treatment group, and that is why they put forward the definition of hypertension a bit lower, and they were trying to control blood pressure more tightly. Next one, please. Drugs available. You all know all these drugs are available. The diuretics, the thiazide loops, and the potassium sparing diuretics. Next one, please. The other drugs are the beta ACEI, you know, ACEI and ARBs, ACEI and ARBs. Next one, please. The calcium channel blockers. There are two types of calcium channel blockers, non-dihydropyridines. These non-dihydropyridines are less antihypertensive, and the dihydropyridine groups are potent antihypertensive group. The other drugs are alpha blocker, central acting drugs. These are not used very commonly. Once upon a time, these clonidine, methyl-dopa, and rizarpine were the drugs those used. And this hydrelazine is a drug that can be used in hypertensive emergency situation. Next one, please. Choice of antihypertensive drugs. The choice, it depends on the degree of blood pressure elevation, target organ damage, clinical cardiovascular disease, or other risk factors, socioeconomic condition of the patient, especially the financial status, possibly of interaction with other drugs, and variation in individual patient response. This is the এখানে থাক আমার নো পরেরটাই চলে যান। এটা আমি দেখেন এটাই বলতে চাই, the initial therapy is ACI or ARB প্লাস ক্যালসিয়াম চ্যানেল ব্লকার, যে কোনোটা একটার সঙ্গে এটা, or diuretic। যেটা হয় যে বলা হয় হলো any elderly patient elderly than 50 should be started with calcium channel blocker, or age less than 50 should be started with ACI or ARB. If the patient is not in control, then just cross. Keep that one, again add from the other group. If not in control, this step 3, the add another group, the diuretic. The another one is diuretic. So add, if it's not in control. This is what is called resistant hypertension. But in that case, you have to reach the full doses of ARB, CCB, and diuretic. Then you can say this is resistant hypertension. And beta blocker at last. If no one can control with all these three, then add beta blocker. Due to some reasons, due to some evidences, beta blocker has been lagging behind among the choices of antihypertensive drugs. I'm not going into the details of those scenarios and the things. Next one, please. Again, this is a choice. I'm judging algorithm. Next one, please. So, during choice of antihypertensive drug, there are some compelling indications of giving drugs and compelling contraindications. These compelling indication and contraindication are used to be a terms in the JNC7 guideline. But these are the standard teachings. Beta blockers, whenever there is heart failure and myocardial infarction, you have to start with beta blocker. But in the algorithm, it is kept in behind. It is in fourth stage. But once the patient has got heart failure, beta blocker comes first. On the other hand, the heart block thake, no. The previous one. Asthma thake, beta blocker is contraindicated. Diuretics, heart failure, systolic blood pressure, must give diuretic. Gout, dyslipidemia, these are the theoretical contraindications of diuretics. ACE inhibitors, heart failure, diabetic nephropathy, severe renal failure. This is a tricky term, severe renal failure. How much severe? The end stage renal failure, if the patient has got aage bola hoto creatinine more than 3, don't use ACI or ARB. But nowadays, more and more evidences are coming that it can be used in more advanced cases of renal failure. So I'm not going into those debates. The other next পরেরটাই চলে যান, আমি এগুলো আর বলার দরকার নেই আমাদের। Next one, follow up and monitoring. The very important, patients should return to follow up and adjustment of medications until BP is reduced or to the target. More frequent visit for stage 2 hypertension or with compelling comorbid conditions, complicating comorbid conditions. তাহলে তাদের ভিজিটটা একটু ফ্রিকোয়েন্ট হতে হবে। এইখানে it depends on the choice of the physician. এখানে কোনো একদম মানে রিজিড হার্ড অ্যান্ড ফাস্ট কোনো কথা নেই। সিরাম পটাশিয়াম অ্যান্ড ক্রিয়েটিনিন লেভেল মনিটর করতে হবে। এটা অবশ্য ইয়ারলি 1-2 বার করে করলে হয়। নেক্সট ওয়ান প্লিজ। After BP is at goal and stable, the follow-up visit will be at 3 to 6 months interval. If the blood pressure is stable and at goal, then you have liberty to give follow-up between 3 to 6 months. But if the patient has got comorbidities like other conditions, then in those situations, more frequent visits might be needed. এইটা ব্লাড প্রেশারের জন্য লাগতে পারে, তার অন্য কন্ডিশন কন্ট্রোলে থাকলো কি থাকলো না সেটাও you have to judge on those scenarios. Next one, please. So improving hypertension, the main thing is that adherence to the regimens. You know, if the patient, so blood pressure treatment is a lifelong treatment, you have to have counsel the patient very adequately that you have to continue this treatment for life. So you have to think of about the social status of the patient, the financial condition of the patient. If the patient has got a very poor class people and you are prescribing the high powered, the ACI or ARB, then it's not reasonable. It will not be prudent to prescribe those drugs in this patient. So you have to prescribe in those situations with very cheap drug like diuretic. And in some situation, you have got those liberty to prescribe beta blocker, though the position of the beta blocker has been put forward in the bottom of the list of the algorithm. But you have to have that judgment to give those drugs very early, because it is very important to continue the therapy for life. Next slide, please. So, how we can improve the treatment adherence. So, as I have told, all these things are the treatment adherence part, counseling of the patient to understand what hypertension is and what can happen if it remains untreated. Next one, please. So I'm almost at the near end, dear sirs, Chairman sir. From the very beginning, it has been shown that, it has been evident that the guidelines are said to be evidence-based. All the guidelines are evidence-based, but there are different recommendations by the different expert groups. This is very, the evidences are the same, because the American experts or the European experts, they judge the same evidences, but their recommendations are a bit different. So we have to be very prudent in choosing those guidelines, but we have to follow anyone you can follow. Treatment must be individualized. There is nothing called cookbook recommendation for the treatment of hypertension. যে আপনি রান্নার বইটা ওপেন করে রান্না করে যাচ্ছেন, দেখা গেল যে পায়েস রান্না করতে গিয়ে পাতাটা ফ্যানে উল্টায় দিল, আপনি পরে পুরো দিতে বলছে হলো 1 চামচ মরিচ, আপনি 1 চামচ মরিচ দিয়ে দিলেন। রান্নার বইটা একেবারে আপনাকে এমন জায়গায় নিয়ে গেল পায়েসের যে একদম শেষ। So this must be individualized. 2 or more antihypertensive medications will be required to achieve the goal blood pressure less than 140/90. আমি again বলছি, less than 140/90 is a moderate recommendation, but for tight recommendation it is less than 120/80. Next one, please, sir. Positive experiences, trust in clinician, and empathic attitude towards the patient will motivate our patient satisfaction, and these are the key in the compliance of the treatment of the patient. And the responsible physician judgment remains the paramount in controlling the blood pressure, in controlling the cardiovascular and renovascular morbidity and mortality among the population. So, Mr. Chairman and expert panelists, thank you, sir. Thank you very much. I have taken much time from you. Thank you very much.
Thank you.
Thank you so much, sir, for your amazing and excellent presentation. Now it's time for the question and answer session. I can see the whole comment section flooded with questions, but we'll be able to answer few of them as the time is short. To start the session, let me request Muhammad Mahfuzul Haq, sir.
Thank you, Prince. Thank you, Professor Mujibur Rahman sir, for an excellent and elaborate presentation of management of hypertension. Actually, hypertension is a big topic, but sir probably has touched all the corner of the management of hypertension. So during the management of hypertension, there are several important things during the evaluation, particularly the cardiovascular risk factor and the hypertension mediated organ damage. And we should not forget about the present symptoms which guides us to identify the secondary causes of the hypertension. So now I'm going to Dr. Professor Julshash Uddin sir to have some comments regarding the management of the hypertension.
Mahfuz sir, we are in the question and answer session right now. So after finishing the question and answer session, then we will. Yes.
Okay,
Yes.
many people. So Muhammad Shakat Hossain has asked a question. Many people have blood pressure 100/60 millimeter in our country without symptom. When they present with blood pressure 138/89, is it hypertension? So may I ask the question to the Professor Mujibur Rahman sir?
Thank you very much, the question setter, Dr. Muhammad Shakat Hossain. This level, you see, we need to have the age of the patient. 138 systolic is normal, 89 is raised, is just marginally raised, and this by definition, by our definition, it is not hypertension. If we stick to the cutoff value below 140 by 190, আমরা যদি এটা ধরি তাহলে this is not hypertension. But you see the later classification, it is less than, it is more than that, then it is hypertensive and you have to treat. But in this scenario, the treatment may be only the lifestyle modifications and the lifestyle changes. So it depends on which classification you guideline are you using. That is very important. So in our understanding, in our guideline, we have one guideline in our country, but that is not included in hypertension definition. So one thing I want to mention that in my lecture, I did not cover the emergency management of hypertension. Actually, management of hypertension and emergency management or crisis, the emergencies, those are the different scenarios, and that needs another class. So I just omitted those part of management of hypertension. Thank you.
So next question is it necessary to it is necessary to treatment to pre-hypertension if lifestyle modification fails to control? What is the treatment of isolated diastolic hypertension? So I'm going to again to Professor Mujibur Rahman sir.
Yes, thank you. Pre-hypertension, if you use the term pre-hypertension, then it means that the patient will develop hypertension subsequently. কবে হবে সেটা আমরা জানি না, but you have the treatment can prevent hypertension, so you have to treat. What is that treatment? It may be only lifestyle modification. You change lifestyle, and after being lifestyle changes 3 to 6 months, you follow the patient and assess the patient time and again. If the patient has got other cardiovascular risk factors and target organ damage, then you have to add the drugs in treating those patients. So it depends on the presence of any other cardiovascular risk factors, and then depends on the presence of any target organ disease in that patient.
So next question is, what is the difference between the hypertensive encephalopathy and malignant hypertension? Sir,
এইখানে একটা জিনিস খুব ক্লিয়ারলি বলা হচ্ছে যে ভেরি হাই ব্লাড প্রেশার, যে আমাদের স্টেজেরও বাইরে, স্টেজ 1 বা গ্রেড 1 এর গ্রেড 2 3 এর বাইরে ভেরি হাই ব্লাড প্রেশার, তখন কতগুলো সিমটমস প্রডিউস করে। সো নাওএডেজ these terminologies are not used, especially the malignant hypertension, because hypertension malignant বলা হতো আগে, একটা ডেফিনেশন ছিল আমরা সবাই জানি, ভেরি হাই ব্লাড প্রেশার মোর দ্যান 180 বাই মোর দ্যান 120, and যদি কারো স্টেজ 4 রেটিনোপ্যাথি থাকে, তার যদি কিডনিতে অ্যালবুমিনিউরিয়া থাকে বা হিমাচিউরিয়া থাকে, and creatinine যদি raised হয় তাদেরকে বলা হয় malignant. Why malignant? This is hypertension. So if they remain untreated, then within year most of the patient will be dying, and that is why they use this term as malignant hypertension. But nowadays the authority in hypertension, they usually do not use this terminology. And the hypertensive encephalopathy, very high blood pressure, and suddenly there occurs some brain functional changes, convulsion, and some deterioration of the level of consciousness is encephalopathy. So if you control the blood pressure, then if the blood pressure will be, so this is the difference between the encephalopathy and malignant hypertension. Thank you.
Choice of drug changes times. Many patients taking amlodipine and atenolol combination with good control compliance. What's the opinion? So that question has been provided our most respected Professor Nazmul Hasan sir. So again I want to go to the Mujibur.
এই প্রশ্ন উত্তর দেওয়াতে স্যার আমার হাত পা কাঁপতেছে স্যার। Thank you sir. You see, once a patient has got a good control with amlodipine and atenolol, so my opinion is to continue that combination. Well, the main target is to control the blood pressure. That control will be beneficial. Whether this atenolol is beneficial or not is controversial or subjected to some of the evidences. Some evidence says that atenolol, that is beta blocker, has got no benefit over the primary prevention of stroke. On the other hand, amlodipine has got tremendous benefit on the prevention of primary prevention of stroke. So as amlodipine is getting that patient, so it is better to continue both of these drugs. This is my opinion. In this scenario, I will not going back to those of the evidences. Those are not favoring beta blocker as a choice of drug. I am not going into those evidences, but because in some situation there are some beneficial effect also. I think you will be agreeing with me that amlodipine is a beta blocker. It will be giving rise to a tachycardia, palpitation, and combination of this atenolol at least would give some of the beneficial effect over those palpitation. So I must say that it should be continued. Thank you, sir.
So up to which level the white coat hypertension may rise? Is there any cutoff value, sir?
আমাকে এভিডেন্স খুঁজতে হবে, মানে হলো সবকিছু এভিডেন্সের উপর ভিত্তি করে অ্যান্সার করতে হবে। You see, a young individual has come to you with some stressful situation, and আসার সঙ্গে সঙ্গে আপনি ব্লাড প্রেশারটা মেপে নিলেন, দেখলেন যে ব্লাড প্রেশারটা একটু বেশি, তার ট্যাকিকার্ডিয়া আছে। So level is not the important, but usually বলা হয় systolic blood pressure around 160 and diastolic blood pressure around 100 এরকম লেভেলে যদি থাকে, ইয়াঙ্গার ইন্ডিভিজুয়াল যদি হয় এবং তাদের মধ্যে যদি আমি কোনো কার্ডিওভাস্কুলার রিস্ক ফ্যাক্টরস না পাই or cardiovascular কোনো টার্গেট অর্গান ড্যামেজের এভিডেন্স না পাই, তাহলে আমরা ধরে নিতে পারি দিস ইজ, বাট অ্যাবসলিউটলি দেয়ার ইজ নো কাট অফ ভ্যালু on which we can say this is white coat effect.
So this question already actually answered by our Professor Mujibur Rahman sir during the presentation. That is the target level of the or the cutoff value or the definition of the hypertension that has been already discussed in the presentation. When will be the first follow-up after commencing the antihypertensive? So I'm going to Professor Mujibur Rahman sir.
Again, there is no cut-off time. কোনো একেবারে হার্ড অ্যান্ড ফাস্ট কাট অফ টাইম লাইন নাই যে আমার এই সময় শুরু করতে হবে। ইট ডিপেন্ডস অন the patient's condition, and the level of rise of blood pressure. If a patient has come to you with raised blood pressure, and raised is very raised, is 200 by 110, and you are prescribing a antihypertensive drug, as he has got the LVH and also some other complications like diabetes mellitus, so he needs frequent visit. He needs a visit within 10 to 15 days. On the other hand, a patient, younger patient, has come to you with a high blood pressure like 160 over 100, then in this scenario, the first visit is not very frequent. You can follow the patient after 1 month, but after controlling the blood pressure to target level and being stabilized, অর্থাৎ আরেকটা সাবসিকুয়েন্ট ভিজিটে দেখা গেল is stabilized, then every 3 to 6 months. Thank you.
Many patients come to us with diabetic nephropathy but BP below the normal range. In this case, what should we do? So this in this point, the compelling indication of AC inhibitor or ARB comes. Actually, this question also had been answered by our Professor Mujibur Rahman sir. And during this period, we also keep eye on the rising of the creatinine and the changes in the potassium level. Next question. Does we prescribe beta blocker in young patient with keeping in mind about the side effect of erectile dysfunction? So beta blocker is rarely used, or it has been put down in the list of the choice of the antihypertensive. So definitely we should not choose it at first, particularly in this clinical setting.
না, ঠিক আছে, এটার অ্যান্সার করার দরকার নাই।
In pregnancy, is there any recommendation for single high dose drug than the combination? So, Professor Mujibur Rahman sir.
In pregnancy, this is again a different subject. In pregnancy, we used to use the drugs other than ARB or ACI. Either ACI or ARB, এই দুইটাকে আমাদের একদম সাইডে রাখতে হবে. We should not use these two drugs, but any other drugs can be used. So in those situations, you just start with some of the calcium channel blocker, beta blockers. These are the choice of drug. And once upon a time, we used to alpha methyl dopa. That was a choice of drug, but nowadays these drugs are not very much used in hypertensive disorders of pregnancy. So you can use one drug if it is controlled, then go up. If any side effects occurs, you add another drug. This should be the policy. This should be the policy. ওই একটা কোশ্চেন ছিল, যেটি ছিল হলো ডায়াবেটিক পেশেন্ট, নর্মাল ব্লাড প্রেশার, এসিইআই আছে, নেফ্রোপ্যাথি আছে, তার কিন্তু এসিইআই অ্যাড করতে হবে, এআরবি অ্যাড করতে হবে, আইদার অফ দি ড্রাগ ইন ভেরি লো ডোজে অ্যাড করতে হবে। এই কথাটা মনে রাখতে হবে, বিকজ লোয়ার ডোজে those drugs may not produce any antihypertensive effect. এটা মাথায় রেখে you have to prescribe. এই কয়েকটা আগে কোশ্চেন এরকম একটা ছিল। থ্যাংক ইউ
Sir, this will be our last question, sir.
Also,
okay.
Serum creatinine electrolyte level at baseline and after starting AC inhibitor in elderly patient. If yes, then what is the recommended follow-up schedule? So, Professor
yes, the answer is yes. Because not in even elderly patients, in every patients, ideally we should see the serum potassium level before starting ACI or ARB. Ideally it should, because very recently I found one patient, young patient, doctor, and he was hypertensive. He was getting one of the ACI for longer period of time. suddenly he got hyperkalemia, like 7.8, 7.9 potassium level. But unfortunately, his kidney function was normal. Is not unfortunate. Is fortunately his kidney function was normal. Only this ACI was responsible for increasing this. That is why the recommendation is once you start once or twice a year, depending on the scenario of your patient, you should follow the patient up in regard to potassium level. Thank you very much.
Thank you, sir, for giving the answer all the question which was asked by our trainee and the audience. So, as we are discussing about the hypertension management, one of the issue is the measuring the risk factors, and we have to quantify the risk factor objectively, and we also the risk stratification should be in objectively measured, and there are several tools regarding that, starting from the framing heart the study. So there are several tools still is used in the different country in different contexts. The bottom line is we have to quantify the risk factors. And so I'm going to Dr. Professor Major Retired Mohammad Julshash sir to have some comment regarding the management of the hypertension.
Thank you very much. First of all, I want to give my thanks and congratulations to the speaker, Professor Dr. Mujibur Rahman, for his nice, deliberate, informative, and fruitful discussion regarding the management of hypertension. It is a very big subject. In this short time, it is very difficult to cover up all the corners of the subject. But even then, he tried to manage the things in a very nice way. Today's session's chairperson, Professor Abul Kalam Azad, Governor SCP, Bangladesh chapter elective, and former president of Bangladesh Society of Medicine. Then my co-panelist, Professor Dr. Enamul Karim, professor and principal of Universal Medical College, and host, moderator, and my dear viewers, the examinees. Assalamu alaikum. I just add something. Just discussion is not there too much. I must congratulate and thank to the SCP and also the Bangladesh Society of Medicine to organize these sorts of sessions for the sake of the day-to-day time, up-to-date of the exam systems. So they must be thanked. And regarding the management of hypertension, there are so many things. I want to just point out, we are running short of time. One thing, the measurement of blood pressure. So regarding the measurement of blood pressure, it is very important because the patients are coming with their assistance, and the patient, especially during the diagnosis, the leveling of the hypertension, and also the changing of the drugs, and also the comparison with the symptoms with other comorbidities. So in these situations, I think the blood pressure measurement is very, very important. In that regard, I just written one dissertation during my part 2 FCPS examination in 1992, in Bangladesh Armed Forces Medical Journal, BFM Journal, the measurement of blood pressure, and in that one, just in the undergraduate medicine and postgraduate medicine, sometimes in postgraduate medicine especially, I want to examine to show the blood pressure. You just measure the blood pressure, because the blood pressure measurement is very important in that sense. It is the confidence of the patient and also the accuracy, because if one patient is diagnosed at level of blood pressure, he or she needs to take it lifelong. And there are so many diversities of medical drug implementation also. And regarding the resistance blood pressure, it was discussed. I want to mention one thing. There are three things for the examinees. The resistance blood pressure for the reason is three. One is non-compliance, and two is the underdose or drug replacement, and the third one is the second to establish the secondary hypertension. So during the non-compliance, the empathy, the Professor Mujibur Rahman told repeatedly, the empathy is very, very important. আমি একটু জাস্ট প্যানেলিস্ট হিসেবে না, আমি জাস্ট একটু ডাক্তার হিসেবে বলতে চাই, because doctors are training in their whole life. পেশেন্ট আসে, অ্যাটেন্ডেন্ট থাকে, তাদের ব্লাড প্রেশার আমরা মেজার করি। আমরা নিজেরা একটু সময় নিয়ে বা একটা দেখে যাতে জিনিসটাকে আমরা ভালোভাবে মেজার করতে পারি, আমরা অ্যাটেন্ডেন্স অ্যাসিস্ট্যান্ট দিয়ে মেজারমেন্ট না করে আমরা জাস্ট এই তিনটা ব্যাপারে আর কি, বিশেষ করে ডায়াগনোসিসের জন্য, মডিফিকেশন অফ দি ড্রাগস এন্ড দি কোমরবিডিটিস ডায়াগনোসিসের জন্য, যেখানে আমাদের ভেরি মাচ ইম্পর্টেন্ট এই জিনিসগুলো আমাদের করলে মনে হয় ভালো হয়। আরেকটা জিনিস যে হোয়াইট কোট হাইপারটেনশন, তো কথাটা আমি একটু মডিফিকেশন করতে চাই। ইট ইজ দ্য হোয়াইট কোট ইফেক্ট ইন হাইপারটেনশন। It is the effect of a white coat effect in hypertension. That is which comes through the sympathetic nervous system. We know that sympathetic nervous system activity increases the blood pressure. So white coat effect. If we allow the patient to be measured blood pressure by the assistant or in the home, not by myself. So question of white coat effect is less. And another one is, one question was asked by the examinees, what is the range of the white coat hypertension? Actually, the white coat hypertension, it is nowhere probably it is written in our practice. I know what I believe. It should be not less than less than 10. If it is more than 10, it should not be that. We should cut off value there 10 millimeter of mercury. In diastolic hypertension, Professor Mujibur Rahman told, SGM Choudhury and other professors, we in our time, actually really it was fact the diastolic hypertension. But some patients are coming, we are discussing about the hypertension. There's so many patients are coming with the low blood pressure. But Dr. Sahab, আমার pressure অনেক কম, আমার pressure অনেক কমে যাচ্ছে। In that case, measurement of blood pressure, the Porotko sound and the type 4 and type 5 sounds, the muffling sound and the last one sounds. In some secondary hypertension, the diastolic pressure if we take the type 4 stage of measurement sound, it should be 0. So in that case, we should take the type 4 stage. So as a whole, we should be careful about this. Otherwise, the session was very much fruitful. Very much fruitful, informative, and I also got benefited also, and viewers should also be benefited. So thank you very much. Thank you all.
Thank you, Professor Dr. Mohammad Julshash sir. Particularly, sir has given the emphasis on the measurement of blood pressure and the elimination of the white coat effect. So not only to eliminate the white coat effect of measuring the hypertension, but also to obtain the representative blood pressure of a patient, we should encourage the patient to measure the out of out of office blood pressure monitoring. So nowadays, out of office BP monitoring, that is home blood pressure monitoring and ambulatory BP monitoring has given the emphasis, because a patient when comes to me, this is just a snapshot of the blood pressure. But what is the blood pressure his patient is having in his house during activities? So that can be that the representative blood pressure only can be obtained in the home BP monitoring and the ambulatory BP monitoring. That's why the home BP monitoring has been given emphasis nowadays. So now may I request our Professor Enamul Karim sir to have some comments regarding the management of the hypertension. স্যার একটু আনমিউট করতে হবে। এনামুল করিম, হ্যাঁ থ্যাংক ইউ স্যার।
এখন শোনা যাচ্ছে?
হ্যাঁ স্যার শোনা যাচ্ছে।
I first of all thank and congratulate Professor Mujibur Rahman for his excellent and elaborate presentation on the management of hypertension. At the same time, I thank Professor Abul Azad for chairing this session. Management of hypertension is a very elaborate and sometimes easy, sometimes very difficult. First of all, the difficulty arises when we record blood pressure. Frequently, patients come with blood pressure recording from medicine shop. In our country, many of the medicine shop people, they measure the blood pressure, and most of the time their recording is wrong. So, blood pressure recording should be done by an experienced person, particularly a medical graduate, not a shopkeeper. This is very important. And again, in the management of blood pressure, it is not only the blood pressure that is targeted, but also the comorbid conditions and target organ damage. These are very important. Comorbid conditions like diabetes, dyslipidemia, smoking, and others. So these are very important in the management of hypertension. And it is very important to stage the level of blood pressure, because according to stage, the drugs will change. This is very important. And again, when we prescribe a patient, we have to give some advice like lifestyle modification, particularly physical activities and dietary habits are very important. And also, smoking should be stopped completely, and patients should not take any extra salt. And they have to take regular physical activity, physical exercise, at least 30 to 40 minutes daily, 5 days in a week. So these are very important in the management of hypertension. And again, I thank and congratulate Professor Mujibur Rahman for his excellent and elaborate presentation. I also thank Professor Abul Azad, Dr. Mahfuzul Haq, Dr. Prince for their excellent job in this session. Thank you all.
Thank you, sir. Sir has given the emphasis on the particularly non-pharmacological management of the hypertension, lifestyle modification, and that's really important, that lifestyle modification. And we also, sir also has given emphasis in the comorbidities, which is not only important in the cardiovascular risk stratification, it is also important. Sometimes comorbidity uh, guides us to a choice antihypertensive. That is the compelling indication. And sometimes we have to also see the any symptoms. Though the secondary hypertension is rare, sometimes we have to look for that. So uh, uh, this session actually was very excellent, and I think the many of the things we can learn during this session from both our expert and the presenter. So at this level, I want to thank all of the speaker and expert. Now, may I request Professor Khan Abul Kalam Azad sir to have the comment and to conclude the session.
Thank you, Dr. Mahfuz. Uh, Again, it was a great show. You know that a teacher making a lecture which is comprehensive, evidence-based, but very easy, palatable. Professor Mujibur Rahman made such a lecture. There are several things. One is that our first of all SCP organizing so many lectures on different issues, and definitely today's was a real very good lecture, which is very important for a doctor to follow throughout his career, not only for the exam but throughout his career, to practice in real life situation. And also we found two great teachers, Professor Muhammad Enamul Karim and Professor Muhammad Julshash Uddin, very soft-spoken two personalities, very empathetic personalities. They were with us in the show, and they talked on different issues, and they have got huge experience throughout their life treating thousands of patients with hypertension with different types of drugs. We began our career with diuretic, and then beta blocker, and then gradually we prescribed so many drugs, and then one after another discovery of newer drugs came into the pipeline, and so we are seeing that some of very good drugs are there to prescribe. So this is one, and I like to say Dr. Mahfuz, the way he was talking, and also he added so many important points with different issues. Thank you very much, Dr. Mahfuz, for your presentation. And also, I want to say that our teacher, because whenever we remember our teachers, especially HGM Chaudhary sir, still I remember in Gallery 1 of DMC, we are learning hypertension, we are learning all cardiovascular, angina pectoris, ischemic heart disease, valvular heart disease. At the time, rheumatic fever was also a very good topic, infective endocarditis, heart failure, all were taught by Professor HGM Chaudhary. And so still we remember in fifth year classes. So it was so wonderful. And also another important point I want to mention, when Professor Mujib was showing different guidelines, and 2004, Professor Mujib, Professor Jalil Chaudhary, and me, we were joined with another great teacher, Professor A.K.M. Rafiquddin sir. He was very interested in treating hypertension, and regarding the cardiovascular, he had a very good training in cardiovascular treatment in the then IPGMR. So we used to see that sir was very happy with the cardiovascular disorders at the time. And during 2004, we went to Paris in a meeting with European Society of Hypertension. We represented Bangladesh, and it was such a wonderful experience at the time, because at the time we did not have enough information regarding treatment of hypertension other than your JNC report. So that was also a very good experience. And I also pray for the salvation of the great soul of Prof. Uddin whenever we learn hypertension. I just will give two emphasis. One is that when you find a patient with hypertension, the blood pressure, either the patient says, because nowadays most of the people, when they come out from their house, they just go to the pharmacy which is located in their mohalla, and a person is measuring the blood pressure. So measurement of blood pressure is very important. What Professor Mujib emphasized. So when you find a patient complaining of hypertension with, or incidentally you diagnose the patient is having hypertension, or it was diagnosed during screening procedure and he has come with that. So give emphasis. You take the history, number one, in details, and you just give emphasis on 5 points. Number one, you establish the presence of hypertension with accurate measurement of blood pressure, and at least 3 measurements are necessary, not only one measurement. 2 measurements on sitting or lying position and one on standing position, and you check for the postural drop. Number two, you see the risk factors, all your demographic profile, cardiovascular risk factor with your dyslipidemia, obesity, waist circumference, any features of your dyslipidemia present in the patient. So all these things have to be noted. This is the second one. The third one, you have to examine the patient thoroughly, starting from the head, looking at the fundus, then you go through the chest and the abdomen. You look for everything, all possible findings. A hypertensive patient can have either primary or secondary. You examine very thoroughly. This is the number three. Number four, then you make a plan to think of your any target organ damage. So again, you re-examine the patient for the evidence of your target organ damage. This target organ damage will be planned by physical examination and doing some laboratory tests. So plan for some laboratory tests if you suspect some target organ damage. And number five, that is very important. You have to plan for a treatment protocol in this particular individual patient for managing hypertension. So you check for comorbidities, because presence or absence of a particular comorbidity will give a guidance to choose a particular antihypertensive. So that is very important. So comorbidities may modify the form of treatment, as Prof. Mujib showed in his slide, that some of the disadvantages or contraindications to a particular type of drug. So you have to find it out for choosing an antihypertensive. This is number one, the 5 point examination of a patient with hypertension. And some important investigation what to be done. Professor H.G.M. Chaudhary sir used to say, you go for a CBC, you go for a urine examination, you go for a serum creatinine, you go for an ECG and a chest X-ray. These are the basic investigation. But nowadays, we add something more. We go for TSH, blood sugar. We go for creatinine. We go for ultrasonography of abdomen. We go for echocardiography. And we go for your serum electrolytes. So if you combine all these in simple investigations for a patient, you can find a way to exclude many of the secondary conditions to produce hypertension. In our time, you used to say you start giving the treatment for primary hypertension. If you find it is refractory or resistant hypertension, then you think of secondary. No. From the very beginning, you have to exclude a possible secondary. So Professor Mujib emphasized it because, on many occasions, it may not be suspected. So suspect from the very beginning, yes, I'll be treating this person as one of the 95% of the community, but we have to find out whether he is one of the 5% in the community. So with these few words, again, I like to say that it was such an excellent session. I can say that all those important, the trials and others to find out the best possible solution. So I like to congratulate Professor Mujib for his excellent deliberation. And also, you saw that Professor Mujib showed his own paper on hypertension. So again, I like to congratulate for making us pride in the world. So with these few words, 2 hours have passed since we began our journey in the evening, and so I like to say with these few words again, thank you, my dear participants. The most important part was that I was reading the questions made by the student. It means they are further advanced. The types of questions which appeared in the screen, it means they study, they have got a very good sense, very good knowledge on different aspects of hypertension. And so the you see your questions were so beautiful. I learned so many things from your questions also. And also again thanks to Professor Mujib because they were wonderfully answered. So no more talk. So with these few words, I like to hand over the microphone to Dr. Mahfuz and to Dr. Prince. Thank you very much. Assalamu alaikum. Good night, everybody.
Sadly, we have come to the end
Thank
of today's program as well as the session. We have learned so many important things from Sir today. Many thanks to the speaker, the chair, the expert panel, and last but not the least, the moderator sir for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us throughout the event, especially those who asked very interesting questions. Hope you got your answer. If you joined late or couldn't see the whole program, there is no need to be worried. You will find the whole program as well as all the previous on our YouTube channel right after the live session finishes. Today was the last program, so see you all on some other programs. Until then, take care and good night.